Hey, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the appointments. This is going over my appointments from a Tuesday. Tuesday here, 20 appointments. I had 40 minutes that were open. The main thing I was working on today was something I call the 30-second foot analyzer. So it's a new kind of it's called a lead magnet on our website. So if you go to centralmasspodiatry.com, you can see what it's like. You're going to see it's offering patients this foot analyzer. It takes less than 30 seconds to help them figure out what their foot problem is. I did it in Google Forms by putting in some pictures about the most common. I would say that probably that 80% of the stuff. I might have some random stuff that doesn't equate, but those, that wouldn't really help them anyway. So I'm testing this out. So if you want to take a look at it, you'll get it. You'll have to put an email in, and then you'll also see how I mark it to my actual list of patients. I have I think it's about 16 or 17,000 patients on there because we collect all their emails. Not all of them are super duper active, but I try to keep in touch with them once a week. So if you want to kind of follow how I do that, you can feel free to join there. So today, this first patient, I've been trying a couple of things lately. I'm trying to skip the first fungal nail visit with the nail sample. I did that a couple of times today, just kind of trying it out to see if I can get the belief there that patients have fungus and they want to start treating right now. The wording I'm using is I'm saying, well, we could take a sample and I can see you back in 3 weeks, which would delay treatment, or we can start treatment as if it is a fungus right now. And that is with or without a nail sample. Because sometimes I get a little burnt with nail samples. I don't know about you. My joke is I'll do a nail sample and I use Quantum, and the patients sometimes get a bill for like $400, and I'm thinking to myself, oh my goodness, like even with like the stuff I'm dispensing and my office visit, it's probably hardly $400, and for taking a little clipping, they're getting $400. So I'm thinking, well, one, I could start clipping and doing the tests in the office, which is one option, I guess, which is probably the smarter option. And then, or the other thing is I would just not send them, so they're not going to get this bill, because sometimes they complain. And it's maybe like once a year patients complain about that, but it's something that I've noticed. Okay, so first patient, this patient came in, he's a 55-year-old man. He had orthotics from another chiropractor. He had 2 pairs. He had a pair of athletic that he called athletic basically because they were a little bit wider, and then he had a carbon fiber pair that were made for his walking shoes, and he wanted another pair, so I made him a pair. He liked 3/4 length, so this is something I learned a while ago. And a mistake I've made is when patients have a certain type of device, you make the same device that they have, because always when you make something different, it's not quite as good. So if they have 3/4 length with like multi-density top cover, you're going to do that. You're going to do whatever they have. If you try to improve on it many times, it doesn't really improve. I also took a nail sample for him. He wanted to treat his nail fungus, and we started him. So he got the terbinafine, got the LFTs, got all of that stuff, and so that's what I did for him as well. Another patient, this was a 43-year-old female. She came in, once again, concerned about her toenail fungus as well. We skipped number one, went right to number 2, and I'm going to see her back in 3 months. We did the LFTs and the terbinafine for her. Actually, I think a couple of these, this one and I think there was another one, they came in asking for lunula, and I don't know about you, but I tend to, unfortunately, talk more people out of lunula than into lunula, but we do have lunula. And we'll go over that. There was a patient that came back after that. There was another patient that came in. This is a 70-year-old with numbness and tingling to the foot. They were concerned about neuropathy. We got x-rays, but really nothing was too bad with him. So just a regular office visit, no follow-up. 61-year-old female came in. She came in for metatarsalgia. And after her 3 sessions of Shockwave, she felt 100% better. I did a little video, so I've been doing little short videos for them. So I use this app, and so I record it right with the patient in the office. A lot of them aren't wanting to show their face, so I'm just doing it about them. So if you look at my YouTube, you can see kind of how I do these. I'm going to do a 1-year follow-up. Another patient came in. He was concerned. He was actually at the hospital where I do surgery. He's a nurse. 62-year-old guy is going to retire in a few years. He had concern that he had a wart, and he saw a lot of our ads on Swift. So he came in because of a wart. It wasn't a wart, it was a exostosis between the fourth and fifth toes. So we trimmed it down. I talked to him about more anatomic shoes, and he'll come back as needed. If it doesn't get better, I recommended doing an exostectomy, but it was not a wart. Next patient was a 52-year-old. She did EPAT number 3, and we're going to do a 6-week follow-up for her. So that was the office visit and my last EPAT kind of discussion. She got that piece of paper where I kind of go over what's next. That's why I do an office visit. Next patient, this was a patient that's being seen for nail care with one of the other doctors, but she kind of liked me or knew me, and she wanted to come back to me because of her Achilles pain. She has Achilles tendonitis bilaterally, but I think it's worse on the right side, and she has equinus. So she got bilateral night splints, she got foam rolling, morning stretch. I did not do the meloxicam as I normally do because of her other health issues. I'm going to see her back in 3 weeks. My goal is that the left side will calm down with just the soft tissue work, and then we can do an ultrasound and most likely shockwave on the right side for this patient. So she's kind of an established patient that knows us well. Next patient was a 56-year-old patient for initial foot exam. They were interested in Onifix. So this patient, she had a very onycholytic nail, and it was kind of detached proximally. So I gave options of Cariflex, which just makes it look good. It's a covering on the toenail, but it wouldn't really make it reattach. Or I could do Onifix to help it to reattach as it grows out. I'm not too sold on it, but it's the best thing I have. Like onycholytic nail all the way back, like only about a third of it was there. What else are you going to do? And just tell them you can't do anything, which is kind of a challenge. She didn't want that. So I also talked about her activity because she had a lot of midfoot arthritis bilaterally, and I talked about that. And I got x-rays, orthotics, and things like that, and she's going to kind of decide what she wants. If she wants the Onifix, she will come back a different time. She did not decide on that today. Another patient, this is EPAT number 3 for a patient that was really struggling with heel pain, and she's had pain for a long time, was really bothering her. And so just so you know, this was a Tuesday, so in this office I had radial and I have an unfocused, that's called a soft wave, so unfocused shockwave. So we're doing those together. And just a word, we have billed a couple of these unfocused shockwaves to Medicare, and we got paid, I think it's about $222. So I think we did it for a couple of patients. So we're thinking about doing it where, kind of like orthotics, where we make them pay and then we refund them if it's covered. So same thing for the soft wave. We could do it and then refund it if it's covered. It seems like it's reimbursing a little bit less than we would charge, so we're charging like $250. But if it's $222, come on, I'll take that all day, and everyone's going to get 6 sessions. So I'm not sure. It's kind of a hit or miss thing whether or not insurance will cover it all the time. We're still kind of testing out the waters. Just so you know about that. But she did 3, and then I said, really, most people are going to need 6 total, so we scheduled another 3. So I did not do my office visit that one. I just scheduled another 3 for her. And then there was another patient. She was here for an orthotic follow-up. I did a video for her. She was having some plantar fascial pain and some ankle pain, and she's feeling much better, so I did a quick video. Just so you guys know how I do the editing of the videos, I record them usually on my phone right into the app, and then it uploads it, and then as I have time, then I'll kind of edit. It has a kind of a word editor, so what happens is it transcribes the video, and you can cut out the words that you want. You can add in little things, and it makes YouTube shorts. And then a virtual assistant once a week goes in and takes all the ones that I've edited and puts them out. I haven't learned how to edit enough to teach them. Once I learn it enough, then I can kind of teach them to do it. Another patient, this is the ulcer follow-up. She has an ulcer on the distal hallux and the IPJ hallux concerning probe to bone. Did debridement today. And she'll be back in 2 weeks. Another patient came in for a comprehensive diabetic foot exam, and this probably should have been scheduled at a different day or a different time, but she came in for that, and I did that for this patient. Most of them I see once a year for a diabetic foot exam. Next patient was an 80-year-old female. She had an ulcer. She had 2 ulcers. They were basically on the left. She has a kind of a collapsed midfoot due to arthritis and a flat foot, and so there's an ulcer there, and there's an ulcer on the other foot. So I debrided both ulcers. She has some calluses I did, and I'm going to see her in 2 months just for nail care. I think they're mostly caused by bony prominences. They're not that deep, so they'll heal in fine. Another patient was here for a matrix follow-up. So that was a real kind of a quick visit. As I've talked before, I actually asked this patient, I said, hey, if I didn't have this follow-up, would you be okay? And she's like, yeah. So I'm trying to figure out, like when I do a matrix, I give them a piece of paper, and I'm thinking if I could add to that piece of paper a couple of other things to look for, like reasons to call or contact the office, and then not have people come back for matrix follow-ups. I'd like to know if anyone else doesn't see matrices back, let me know. Send me an email, Donna at Podiatry Practice Mastery, how it's working for you. Like I'm thinking about having just my normal paper where I give them post-matrixectomy, and on there have like a QR code that they can look up, like, okay, what would it look like week 1, week 2, week 3, and what is the thing that I should call the doctor about or contact the doctor with contact information on there. That may be a way so I can reduce these low level visits, what I consider low level. So that's what my thought is. And that's what I asked the patient. She said she would have been fine doing it that way. Next patient was a 48-year-old female. She's going to be getting married soon, so she really wants cute-looking nails. So we took a nail sample, and I started her on terbinafine. I just kind of skipped the first visit with the nail sample, and I went right into the treatment. That same patient afterwards is another patient with a nail patient. She as well wanted the nail, so I started terbinafine for her and LFTs. I guess you can see here, I don't know, they're sending all the nail patients to me here. Then another patient was EPAT number 5. He is doing well. He has one more. Another patient, 60-year-old female that came in. She was concerned about nail fungus, so I took a nail sample. See her back in 3 weeks. Another patient was a 42-year-old. She was follow-up after Achilles treatment. Now this was interesting. This patient, so I always do my visit 1 and then visit 2. So for Achilles and plantar fasciitis, they're tending to get meloxicam for 2 weeks. Then they're getting foam rolling, night sprint, morning stretch, and shoe recommendations, UFOs. Now this patient, and I'm finding more and more patients that if it's primarily caused by equinus or tightness, a lot of them, or this one specifically, got totally better. She had no pain to her Achilles afterwards. So I think those are ones that they don't need an ultrasound, they don't need Shockwave, and she was just really pleased with some of the stretching exercises that I gave her, and she's going to continue to do them, and she does not need a follow-up. And the last patient was a 10-year-old kid. This is a little boy. I'm treating his mom for fungus, and mom's feeling all guilty because the boy now got fungus in his toenails. He's 10. I still think oral is better, but she's having a few stomach issues with the oral, so she didn't want that. So for him, he wanted to do the lunula. So I did a lunula along with Formula 7. So I do very little Formula 7, and I do very little lunula. But in this case, he wanted to do it this way. The parents did. So the way I do lunula, I do weekly appointments for 4 weeks, and then 2-month break, and then a 5th, and then 2-month break, and then a number 6th. And they're going to get the Formula 7 and do the other stuff for this one. So that's a little 10-year-old boy. That's how I'm treating it. He still may need the oral in the future, but mom didn't feel comfortable with that. So once again, I hope you guys enjoy this. If you find this beneficial, please put a little post here wherever you're listening to this that you like it, that it's beneficial. By doing that, it'll get out to more people. And if you have other friends that are podiatrists, please send this to them if you find it beneficial. Any of the content in here is beneficial. Okay, thanks.